Doing high yield systems, starting with CVS, embryo. So heart morphogenesis, first functional organ in vertebrate embryos. Four spontaneous beats spontaneously by week 4 of development, right? So you can remember week 4 by thinking about the cavities in the uh, heart. So there's like two ventricles, two atria, so that's four cavities. Uh, Cardiac looping. Primary heart tube loops to establish left-right polarity begins in week 4 of development. Okay. Uh, Defect in left-right dyning involved in left-right asymmetry, right? So that's when you have dextrocardia. That's when you have the heart on the other side, or the epic. You can feel the epic beat on the right side on the fifth intercostal space instead of the left. It as seen in Cartagner syndrome. That's the one where you differentiate between this and cystic fibrosis. Septation of the chambers. Okay, so uh, right, so four chambers, not cavities, but four chambers. So week 4, it starts beating. Atria. Septum primum grows towards endocardial cushion, narrowing ostium primum. So this is septum primum right here, and this is your endocardial cushion. So first thing that happens that it goes to this goes towards that, and wait, yeah. So septum primum, and this is called the ostium primum between the two. This will change as it goes, as it develops, right? So this is called different names, but for now it's ostium primum, and septum primum goes towards endocardial cushion. That's it. Second, ostium secundum forms in the septum primum due to cell death. Ostium primum regresses. Okay, so after there's a development here, let's make that green. Right, so after this thing goes and grows over here like that, get a little thicker, too thick. Okay, so after that grows, what happens? Some parts of the septum primum, uh, apoptosis happens, so it cell death happens, and when cell death happens, the gaps now are called ostium secundum. Okay. Okay. So now you have ostium secundum. So ostium secundum forms in septum primum due to cell death. Ostium primum regresses. Then three. Septum secundum develops on the right side of the septum primum. Okay. So okay. Septum secundum develops on the right side of the septum primum, as ostium secundum maintains right to left shunt. Okay. So again, right to left shunt means this one is gonna push over here, right? Because you have to remember it's still a fetus, right? So they don't have all the cardiac muscles built. So majority of the blood coming in. Okay. So majority of the blood coming in are from the superior vena cava and the inferior vena cava. So the force of that is gonna build up the right to left shunt for now, okay, until the baby is born, and then the left ventricular, there's less resistance in the lungs, and there's left ventricular mass, like the muscles that will work as well. So that will change the polarity of the shunt. But for now, it's going to be right to left shunt. So this is important. And fetus, there's right to left shunt because of the blood coming in from the thing, and there's too much resistance in the lungs, so it can't go through the pulmonary artery, so it goes through the ostium secundum. Okay, so as ostium secundum maintains right to left shunt, then what happens is septum primum. So now we have this septum secundum forming, and we have ostium, right? So what we're gonna have now is, let's do this blue. So this is gonna grow towards the cushion as well, and this is gonna come up here as well, right? And we already have ostium secundum. So septum secundum develops on the right side. This is the right side of septum primum. That's the septum primum. As ostium secundum maintains the right to left shunt. So as this is developing, right, there's still some gap here, so the blood's still going to flow through here to here. Okay. So over here now, we have septum secundum expands and covers most of the ostium secundum, right? So this was ostium secundum, so it's going to come in and block that up to there. The residual foramen is the foramen ovale. So it covers it, but it's not attached to this yet, the septum primum, right? Then you have the remaining portion of the septum primum forms the one-way valve of the foramen ovale. So now you have this septum. Okay. So this thing now is a valve, right? So this thing is a valve. So when this thing is coming in, this is going to open up and let it flow through and then come back, flow through, come back, flow through, come back. Okay. Why is that there a pulse? It's not that it's a pulse more so. It's just that the mother's pulse is pushing the blood through, so that pulse is going to transfer. That's why, it goes like that. It's very minute, so okay. So septum secundum expands and covers most of the ostium secundum. Then the residual foramen is the foramen ovale. Remaining portion of the septum primum form the one-way valve for foramen ovale. That just means that it can go from here to here, but that's it. It can't come from here to here, because when it does that, it's going to push septum primum against septum secundum and closing the valve, so it can't do that. So it's a one-well valve. Septum primum closes against septum secundum, sealing the foramen ovale soon after birth because of increased left atrial pressure and decreased right atrial pressure. So why is there decreased right atrial pressure? It's because the lungs have opened up now. So right atrium can go into right ventricle, and then right ventricle can enter the pulmonary arteries. Okay. That's why there's a decrease of this. And now there's before there was like zero pressure in left atrium, but now there is some pressure coming in from the lungs as well, because now it's pushing the blood into it, right? Although the pressure is not going to be too much, because remember, they're not like big vessels, it's just small. So it's going to be like 5 mmHg of pressure kind of thing. Okay, compared to aorta is 190. Okay, septum secundum and septum primum fuse during infancy, early childhood. Okay, so in the early childhood, you still have this valve functioning. Not functioning, but it's still open, right? It's not fused to septum primum. So they're saying that it fuses during infancy or early childhood. So this happens after birth. Okay, so forming the atrial septum. If for some reason there is a cyanosis of some kind, we try to keep this open, or we try to keep the PDA open, or one or the other, to maintain the circulation. They'll come in patho, I guess. So yeah, so now we have degenerating septum primum. This one we don't need that, and this and this make the valve, and then after they get fused, it's closed. Then no blood goes by. Okay, so patent foramen ovale, that's caused by the failure of septum primum and septum secundum to fuse after birth. Okay, so most are left untreated, can lead to paradoxal emboli, venous thromboemboli entering the systemic arterial circulation through right to left shunt, as can occur in atrial septal defect. Right, so what does that mean? Say there's a question about a person who was on a road trip, or he's been traveling to tropical islands because he's not a doctor, so or a student, so he can travel and enjoy his life. So he takes the plane, right? So what's the number one thing that can happen for step one if you're on a plane? It's DVT, right? So deep venous thrombosis. Then that gets detached and becomes an emboli, and then it goes through the system, right? So normally the emboli uh, goes through the system from the right atrium to right ventricle to pulmonary artery and gets stuck there, and that's why you have respiratory distress and respiratory embolism. But sometimes what happens is it doesn't just end up in the uh, it doesn't end up in the lung. Instead, it ends up in the brain. So how does that happen? Because it's hard to get through the lungs, right? Because it has a lot of narrow arteries, so it's impossible to get through that. It's kind of acts like a sort of a filter, right? So what happens is it goes through this. So sometimes when um, they're they're sitting down and then they get up, so there's a reduction in venous return, so that can make the shunt go from left to right to right to left, right? Or any activities that does a temporary reversal of the shunt. So then this thing, if it's not fused, the embolism or embolus will come in and then flow through here, right? So it comes from superior vena cava. Sorry. Okay. So it can come from superior vena cava or the inferior vena cava, right in here, and then the embolus can just stay here somewhere and just keep flowing over here, or it can go through, right? But there could be chances that while this is here, you do something or some kind of activity that makes this go from a left to right shunt. So left to right is just going from this to this, or left ventricle throwing the blood into the aorta. Instead of that, it's going from the right atrium to left atrium, right? So it flows through that to there. Then this goes after everything's normalized again. Then this goes from left atrium to left ventricle, and then through the aorta, and from aorta to the coronary to cerebral, right? And then you have a embolus in the brain causing stroke and ischemia, right? So that's how that happens. So that's what this means, that it can lead to paradoxical embolus, emboli, venous thromboemboli entering the systemic arterial circulation. So now, since it came from SVC or IVC, that those are veins, right? Not arteries. So that's why it can enter from venous blood into the oxygenated or arterial blood, right? Which is going to be in the left atrium. So it can lead to paradoxical emboli, which is venous thromboemboli entering the systemic arterial circulation through right to left shunt, as can occur in atrial septal defect. Okay, so remember, atrial septal defect happens because there's a failure of fusion between septum primum, the green one, and septum secundum, the blue one. Okay. Heart morphogenesis continued. Okay, so now we're doing ventricles. So how does the ventricle develop? So where we ended up was this septum right here has been made, and this is the endocardial cushion. Okay, so now we have the so let's read one muscular interventricular septum forms. So now this is the muscular interventricular septum right there. Oops. Right there. Right, it's between the two ventricles, right there and there. Then we have aorticopulmonary septum rotates and fuses with muscular ventricular septum to form membranous interventricular septum, closing the interventricular foramen. So we have the interventricular foramen right there. Okay, so what happens is the aortical septum rotates, right? So this is the aorticopulmonary septum, And then what this is gonna go, actually it's gonna go the other way. So this is attached to this, and imagine there's a wall right there, right? So a wall that's attached to this is now being twisted, right? And it's on the back there, so you can't see this side on over here. But then you have this side and twisting it. So now this side is behind here, and this is a new side here, right? So that's how it's twisting. If you can make that understanding. So just imagine you have like a, I don't know, let's say a piece of clothing that's crumbled up. So you rolled up the piece of clothing, right? So when you're rolling it, that's twisting it, right? So that's how it twists over here, right? So imagine your hand is here and your hand is here, and this hand is rolling forward and this hand is rolling backwards. So that's the kind of twist that's happening here. Okay, so aortical pulmonary septum rotates and fuses with the muscular ventricular septum. So these are the muscular ventricular septum, right? This is the interventricular and this is the muscular ventricular septum. So this one attaches to this side and this end attaches to this side. So with muscular ventricular septum to form membranous interventricular septum. Okay, so it does that and then it makes this as well. So this is going to attach to this, right? So that's how it's going to be attached to muscular and interventricular septum. Okay, closing the interventricular foramen. Since this is the foramen, so if you can imagine if this is attached to this from here to here, all of this going to be covered up with, you know, the septum. So there's no foramen now. That is ugly. Okay. So now we have growth of endocardial cushions separates atria from ventricles and contributes to both atrial septation and membranous portion of the interventricular septum. Again, growth of so that's the endocardial cushion. Separates atria and ventricle. Okay, so it separates the atria and the ventricle and contributes to both the atrial septation and membranous portion of the interventricular septum. So this, you can imagine, is the important structure, right? Because this is the structure that divides the atrias and the ventricles. That's all it's saying. So it separates atria from the ventricles and contributes to the atrial septation. So it also divides the two atrias, and because that's right atrium, that's left atrium, so it's going to divide those two. And now that it's over here, it's going to divide the two ventricles as well, and ventricle and atria and ventricle as well. Right? So what happens when this doesn't fuse to this, right? So you get a ventricular septal defect. Most common congenital cardiac anomaly usually occurs in membranous septum. So when this fusion doesn't happen, this is the interventricular foramen stays open, right, on this side. This is fused, so you won't have RA and RA and RV or LA and LV, but you will have LV and RV communication, right? So again, ventricular septal defect, most common congenital cardiac anomaly, usually occurs in membranous septum. So that's your membranous septum. Okay, and that's the end of the hard part. Outflow tract formation, neural crest cell migrations, which leads to truncal and bulbar ridges. So since we need to know what those are, let's just bring this over there. Okay, so when it's made, this is what the thing's going to look like, right? So okay, so you have neural crest cells, cell migration. Remember, there's epiblast, hypoblast, and then it turns into like bilaminar disc, turns into the three layers, endoderm, mesoderm, and epiderm, or whatever, ectoderm. Sorry, right? So the bilayer disc. This is where it comes from, neurocrest cell migrations, right? So then you have truncal and bulbar ridges that spiral and fuse to form aortico pulmonary septum. Okay, so that's this part right here. And then you have ascending aorta and pulmonary trunk. So after this thing twists around like that, these arrows are showing you the twisting of it. So this doesn't move. It's this part that moves. So that's the way. That's why it causes a, you know. Again, imagine you're holding on to this end, right? You're holding on to this end, and then you're holding on to this end, and this is not moving, but you keep twisting it this backwards, right? Or the way the air is going. So what's gonna happen? You're gonna have a roll of clothing that's gonna end up like knots with like a little rolled knots, right? Like that. So that's how the heart is formed. Ascending aorta and pulmonary trunk. So you have, this is the truncus arteriosus. So that's the truncal, and this part is called the bulbar part. Okay, or and then the ridges would be the bulbar ridges. So that spiral and fuse to form aorticopulmonary septum. It leads to ascending aorta and pulmonary trunk. Just to be thorough, this is what I mean. So roll clothing. Hopefully nothing bad comes up. So yeah, some kind of like that, right? So not this, you know, organized, but like just a random, say, a towel, right? So when you roll it and then you hold one end, the other end, and then you keep rolling this end, but not move this, you're gonna get a little knot that looks like the heart, like that, right? Okay. Conotruncal abnormalities associated with failure of neural crest cells to migrate. So you're gonna have transposition of great vessels. Okay, that means rather than having, let me just go with that part. Where'd it go? It's still in physio. Okay, so transposition of great vessels. Rather than having the pulmonary arteries in the right ventricle, you have the aorta in the right ventricle. And rather than having the aorta in the right ventricle, you have pulmonary arteries in the left ventricle, sorry. Rather than having it in the left ventricle, you have pulmonary arteries in the left ventricle. So you can imagine that this is a closed system, right? Because the blood comes from the lungs, enters the left atrium, goes to the left ventricle, then this pumps it out into the pulmonary artery instead of the aorta, right? Then it goes back to the lungs, comes in and that. So you're gonna have cyanosis, right? Cyanosis is basically no oxygen. Okay. Tetralogy of Fallot is a triad of 4 things. We'll do that as well. Persistent truncus arteriosus, we'll do that as well. Okay. Valve development, aortic. So these are just the outflow formation abnormalities. Okay, these 3 at least. Then you have valve development, aortic pulmonary, derived from endocardial cushions of outflow tract. Mitral and tricuspid, derived from fused endocardial cushions of the AV canal. That's atrioventricular canal. That would be your mitral and tricuspid, right? And these are your aortic and pulmonary valves. Valvular anomalies may be stenotic, regurgitant, atriotic, for example, tricuspid atrasia, or displaced, for example, Epstein anomaly. So stenotic is it's stenos, so there's no flow, or it increases pressure, and that's when it opens up. And then you have regurgitant backflow of the blood, and or atriotic, like tricuspid atrasia, so you don't have a valve there. Or displaced, like Epstein anomaly. So it's the tricuspid gets there's atrialization of the ventricles, right? So what that means is normally you say this is your uh, right ventricle and this is your uh, right atrium, right? And then you have a valve there. But now what's happening is your atrium in Epstein anomaly, it extends into the right ventricle, and now your ventricle that used to be like that, now is like this. Okay, so it has atrial part is in the ventricle, so it's called atrialization of the ventricles. Okay. Hold on, let me check. Atrialization of the ventricle, it means, right? Okay. Now we're doing aortic arch derivatives, and they develop into the atrial system, right? So first is max. That's the maximum number you can have in a classroom, I guess. So part of maxillary artery, branch of external carotid. First arch is maximal, right? So maxillary artery is a branch of external carotid artery. Side note, you guys should know the branches of external carotid artery. They're like 8, right? So you have, starting from the top, you have facial artery, then the tongue lingual artery, then the thyroid, so superior thyroid, and behind it you have ascending pharyngeal artery, and then you have the ears, so posterior auricular artery, and behind it you have occipital artery, superficial temporal artery. So part of this would be the maxillary artery, I guess. Right. So maxillary artery, external carotid artery. First arch is maximal. Then you have second stapedial, S for S, so stapedial artery and hyoid artery. Second stapedial artery. Okay. Okay, so where is that? So we have external carotid, and you have internal carotid here. You have common carotid coming in and making this. We don't have first here. We don't have second here either. Okay. So the third is common carotid artery and proximal part of the internal carotid artery, right? So this would be the proximal. Anything above would be distal. So when you're doing proximal and distal, you're always thinking in terms of where the core is in your body, right? So anything near the core would be proximal. Anything away from the core would be distal. So that's what it means. Common carotid artery and proximal part of the internal carotid artery. So that would be this part. C is the third letter of the alphabet, so you can remember it like that. So the third arch is derived from C for common carotid artery. Okay, and then you have the fourth aortic arch, right? This part on the left aortic arch. On right, it makes the proximal part of the right subclavian artery, right? That thing right there. So fourth arch, four limbs, systemic. This is the important one, the fourth, because it's not the same on both sides, and the sixth as well. So this is the proximal part of the pulmonary arteries, and on left only. Okay, so this is the left side, so it's only on the left, and this is the one that makes the ductus arteriosus. That's why it's the important arch. So sixth arch equals pulmonary, and the pulmonary to systemic shunt. That's the ductus arteriosus. Okay. So why does this exist? Right? Maybe they tell us here. But yeah, they'll tell us over here, so we'll do it there. Okay, so again, revision. First is the maxillary artery. Second is the stapedial artery. Third is the common carotid artery. Fourth, on the left, it makes the aortic arch, and on the right, it makes the right subclavian artery. And on the sixth is it makes the ductus arteriosus. Only on the left. Okay. Nothing on the right. So here you have right recurrent laryngeal nerve loops around product of fourth arch. Okay, so the fourth arch is right subclavian artery. So right recurrent laryngeal nerve goes around it or loops around it. Remember that. It's part of an anatomy question. And then you have left recurrent laryngeal nerve. Okay, so this was right recurrent laryngeal nerve, and this is the left recurrent laryngeal nerve. That's easy to remember because it's right and left. And it's laryngeal loops around the product of sixth. That's the important one. Okay, ductus arteriosus. Okay, and this would be the arch by the fourth. Right on the left, it makes the aortic arch. Cool. With that, heart embryo. So embryonic structures, and it gives what it gives rise to. Okay, so truncus arteriosus, ascending aorta and pulmonary trunk. Okay, that's the initial part of the thing that goes like, you know. So see, this is the heart, this is the aorta, right? So it's this part. This is called the ascending, and this is like the whole aorta, right? So this is descending. This is the aortic arch, and the thing that attaches this to the heart. Between the arch and the heart, it's the ascending aorta. Okay. So the truncus arteriosus, it's in the name, right? It makes the two trunks, the trunks for the aorta and the pulmonary trunk. Then bulbus cordis. This is the smooth part, outflow tract of left and right ventricles. Okay. These are the ventricles, and left and right smooth parts are made by bulbus cordis. Primitive ventricle, that's trabeculated part of the left and right ventricles. Okay. You have primitive atrium, trabeculated part of the left and right atria. Then you have left horn of sinus venosus, coronary sinus. Okay. Then you have right horn of sinus venosus. Okay. Smooth part of right atrium. I'm going through this because they don't really test you on these. So endocardial cushion, atrial septum, membranous part, or the interventricular part. We already did that one. Endocardial cushion, so it makes the septums. And the AV and semilunar valves, right? So atrioventricular and the semilunar valves. Then you have right common cardinal vein and right anterior cardinal vein. This makes the superior vena cava. Posterior cardinal, subcardinal, and supracardinal veins. That's inferior vena cava. Okay, and then you have primitive pulmonary vein, which makes the smooth part of the left atrium. There's no point of spending time on this because we probably forget it as soon as we're like on the third page, right? But the ones you should remember, I'll just go over that one. If they ask you, they'll ask you about the truncus arteriosus because that's an easy one. They might ask you about what makes the superior vena cava and the inferior vena cava. I don't, and maybe this too. Left, no, they don't ask this. So, yeah. do these on your own time because I'm not going to bother with them. Okay. Fetal circulation. So this is an important topic. Um, the questions can come like, okay, so how uh, which vessel takes out the deoxygenated blood from the fetus, or which one brings in the oxygenated blood from the mother, uh, or which artery travels through the fetus that carries the oxygenated blood, or vice versa. So these are the type of questions they'll ask, and they might even ask what is the first. No, wait. What did they ask? Which? Okay, a blood that comes through the umbilical vein. Uh, it'll come to me as we go along. So let's read this. Blood in the umbilical vein has a PO2 of approximately 30 mmHg of pressure and is 80% approximately saturated with O2. Umbilical arteries have low O2 saturation. To get this is why mothers during pregnancy have increased uh, blood volume, have hypertension, increased GFR, and all that stuff. Is to reach this. So they increase blood mass, blood volume, everything to have this happen. And they also hyperventilate during pregnancy, right? Normally it's around maximum is around 20 breaths per minute, but for pregnant ladies it goes higher up. Their heart changes as well; it remodels a little, all that stuff, and so that the fetus can have 80% saturated oxygen. If I said baby, I'm sorry. I know that's a controversial topic. Okay, three important shunts. First is ductus venosus. Okay, so what's the importance about this? Its blood entering fetus through the umbilical vein is conducted via the ductus venosus into the IVC, right, bypassing the hepatic circulation. Okay. So it's again, you don't need this kind of circulation because you don't have anything in your abdomen, right? So you don't need the portal circulation yet. The splenic systemic circulation, right? You don't need that. So initially what it's going to do is just going to bypass it because you get your nutrients and stuff in the fetus from the mother anyways, so you don't need it from here, so there's no blood there either, and obviously the fetus is not having chips or pizzas or anything, so there's no point of that either. So it bypasses the whole hepatic circulation, so it goes from here, so it starts from here again, the placenta comes in the umbilical vein, 80% saturated oxygen. Remember, it's flipped around. It's vein, but it's still oxygenated blood. So it bypasses this. And how does it do it? It does it through ductus venosus. After it bypasses it, what happens? It goes into the IVC. Okay, and this is, I think, the one that they ask. The umbilical vein, which one after the first duct it passes, or after it travels through the duct, which vein does it go into? So it's the IVC, not the superior vena cava, the inferior one. Okay. Most of the highly oxygenated blood. Oh yeah, they also ask which chamber will have the highest oxygenated blood. So that's the question I was looking for. Okay, so they ask in a fetus which chamber will have the highest oxygenated blood. So that would be your right atrium. Okay, normally in a normal person it's the left atrium, right? Because it comes from the lungs after getting oxygenated. So right atrium first, and then it goes to the left atrium second, and then the left ventricle, and then through and through. Why? Because there's no point of going into right ventricle. Even if it does, it's going to be backed up by the resistance of the lungs, so it's going to be backflow of, or like, stagnant blood kind of thing. Not stagnant, but it's very less amount of blood that goes into the lungs. So most of the highly oxygenated blood reaching the heart via the IVC is directed through the foramen ovale into the right atrium, right? So it goes through that. Then we have, so that's another thing that happens in a baby that doesn't in a normal person because it's fused. Which ones? The septum primum with septum primum with the septum secundum, and this is a one-way valve, right? And with the right to left shunt. We have deoxygenated blood from the superior vena cava, passes through the right atrium, goes to the right ventricle, and goes to the main pulmonary artery, right? And so why is this not stagnant, right? I said that there's resistance in the lungs and everywhere. So what happens to the blood that goes through this? If the blood doesn't keep moving, it's gonna clot, right? So what happens is there is a bypass over here going from the pulmonary artery straight into the aorta, right? So that bypass is called this ductus arteriosus. So SVC passes through the right atrium, so it comes from up here, so it has a momentum going downwards, right? So it goes down through and through, whereas IVC has a momentum going this way. So this momentum is going to take it to the right ventricle into the pulmonary artery, and from the pulmonary artery, it's going to go through the ductus arteriosus, right? So main pulmonary artery to ductus arteriosus to the descending aorta, okay? And the shunt is due to high fetal pulmonary artery resistance, okay? So the lungs are creating the resistance. And then after it reaches that, it just goes through and through, downwards. Cool. At birth, infant takes a breath. So when that happens, the lungs inflate, and then the resistance against the... Because how does the resistance happen, in case you can't make that out? So this is the vessel, and the lung is... So imagine all the vessels are like this, right? And it's in the lungs, right? And lungs are deflated, right? So it's pushing downwards onto the vessels. So when it's inflated, what happens is now it's inflated, and now the vessels are not getting pushed external force, right? By external force. So now the resistance is decreased because of that. So decrease in resistance in pulmonary vasculature leads to increase in left atrial pressure, right? Okay, so let's get rid of these. Okay, so at birth, a decrease in resistance, increase in pulmonary vasculature, so increase in left atrial pressure. So normally, since there was nothing coming from the lungs into the left atrium, it was just the amount that was coming through here, right? Which wasn't much. So now there's increase in pressure because now it's getting it from the lungs itself, right? So that's why there's increase in left atrial pressure versus the right atrial pressure. So now the shunt is gonna reverse. Okay, so left atrial pressure is increased versus the right atrial pressure. So then the foramen ovale closes, now called fossa ovalis. Okay, so increase in O2 from respiration and decrease in prostaglandins from placental separation will lead to closure of ductus arteriosus. This is an important line. Okay, so you need a decrease in prostaglandins for that, and you need closure. You need increase in oxygen. and decrease in prostaglandins to close the fossa ovalis. Okay, that's why if for some reason there is a patent or patency, we give NSAIDs, for example, indomethacin, ibuprofen, or acetaminophen helps close the pain ductus arteriosus. Okay, they didn't talk about ovalis. So, in case there is, for some reason, cyanosis because of some abnormality, we would try to keep this open by giving them prostaglandins. Okay, so as long as you keep giving the prostaglandins, these two won't fuse, and that is one of the methods we keep the circulation saturated. Okay, okay. So say this thing, prostaglandin. Sorry, the ductus arteriosus stays patent. That's called patent ductus arteriosus, so PDA. We can help it to, you know, regress or close by giving indomethacin or ibuprofen or acetaminophen, which help close the patent ductus arteriosus. How? It decreases prostaglandin. So ligamentum arteriosum, remnant of ductus arteriosus. So after it's closed in adults, it's known as ligamentum arteriosum. So the fate of PDA or ductus arteriosus, just ductus arteriosus, is called ligamentum arteriosum. Okay, endomethacin ends the PDA. So prostaglandin E1 and E2 keep PDA open. So we also try to keep this open as well in case of cyanosis. So whichever one, one or the other. I guess it's usually this one, not the ovalis, fossa ovalis, but it's going to be this one that you try to keep open. They won't test you on the ovalis one, I guess. So we give prostaglandins to do that. Okay, fetal postnatal derivatives. Fetal structure. How much time do we have? Okay. Fetal postal derivatives. Fetal structure, postnatal derivative, and nouns. Ductus arteriosus, ligamentum arteriosum, near the left recurrent laryngeal nerve. Ductus venosus. So that will turn into ligamentum venosum. Oh yeah, remember, on this side it's this, and on the subclavian side it's going to be right recurrent laryngeal nerve, right? That was over here, this part, that told us about that. And this was a derivative of fourth arch, whereas on the ligamentum arteriosum is product of sixth arch, or PDA was product of sixth arch. Right? Okay, foramen ovale is called fossa ovalis. Then you have allantoin. This is an important one. It's called the median umbilical ligament. We'll come across this in GIT as well. Urchus is a part of allantois between bladder and umbilicus. This is important because if there's some bits that didn't fuse and others did, then that'll create a cyst with urine inside. So that's what's important about that. Allantois turns into urchus. Okay, so patent allantoin or patent urchus, I guess. One or the other. Umbilical arteries, medial umbilical ligaments. So that's what that turns into. And then you have umbilical vein, turning into ligamentum teres hepatis, round ligament. This is an important structure as well. It's contained in the falciform ligament. So we'll do at least like 3 of these in GIT or repro. I forget now. Probably GIT because that one is on like the liver, in front of the liver. Okay, we have anatomy. Oh yeah. So before we go on, LA mass, myxoma, amorphous extracellular matrix, mobile mass, and then you have thrombus, which creates the atrial fibrillation or flutter. Uh, the difference between two is that this one is adherent to the cardiac endothelium. Remember this? Just recently on the group, someone put up a picture from Twitter. Not a picture, but a video. So I think I have that open here. So this is a myxoma, the one that looks like Casper the Friendly Ghost. Right. So that's hypnotizing. But so that thing right there, the vegetation or like whatever, the growth here is called the myxoma, right? So the definition of it is that it's amorphous extracellular matrix, okay? And it's a mobile mass; it moves. Whereas the adherent one would be, say, this is a valve, and then this is a mitral valve with the atrium like that, right? So myxoma would be attached to one of the valves over here, right? The one that moves. But the thrombus would be like somewhere here, inside this layer over here, attached to that, or but it's not gonna move with this. But what's it gonna do? So say when this opens up, the blood goes here, right? Normally, if this wasn't here, but now that this is here, when this opens up, this is gonna create a different type of suction. So now there's a turbulent flow, right? Now that it's gonna go like this, and then this, and then it's gonna go through because of this. So that's what it creates, which is not good, because that will lower your diastolic as well and mess up your whole rhythm, to the point where it creates arterial fibrillation or flutter. Okay. Also, you have pulmonary veins coming in here, and near that, you have the AV valve or so. No, not AV valve. Sorry. You have something there. We'll do that then. Okay, so anatomy. Heart anatomy. You have left atrium is the most superior part of the heart. So that's left atrium. Uh, Normally, this is how you're going to see it. Okay, this is how you're going to see a photo on a chest scan. So left atrium will be the one closest to the aorta. Okay, it goes pulmonary vein, then this thing, and then aorta, and on the middle you have left atrium. Left atrium, again, just imagine yourself, the one outside touching the outside wall is the right ventricle, and the side wall is going to be the left ventricle, and the one like right behind your throat is going to be the left atrium, and the one on your back is going to be the right atrium, right? So left atrium is the most posterior part of the heart. Enlargement of the LA or left atrium, for example, in mitral stenosis, can lead to compression of the esophagus or dysphagia and or the left recurrent laryngeal nerve, a branch of the vagus nerve causing hoarseness, uh, Ortner syndrome. Sorry. So this is your esophagus, right? This thing. So what it's saying is, say this thing, there's a enlargement of left atrium. So instead of this, it becomes as big as this, right? So what's it gonna now do? It's gonna push onto this esophagus, right? So what does esophagus do? It travels. It's your food passage, right? So if something's pushing against it, you're gonna have a hard time swallowing. So that's why it causes dysphagia. And there's also, remember, there was a left recurrent laryngeal right there, because this is aorta, and then it goes from here, from the right side to the left side, like that, right? The aortic arch, I got that, like that. the aortic arch right there, and the aortic arch has left recurrent laryngeal nerve, so that's gonna do that other color. Right, so aortic arch, so that's also gonna get affected right there, I guess, because that's where the recurrent laryngeal nerve is. It's around the sixth one, or the PDA. Okay, so right ventricle is the most anterior part of the heart. Okay, again, that's the one that touches your chest wall or thoracic wall. Uh, right ventricle is the most anterior part of the heart and most commonly injured in trauma. They will test you on this, so remember, this is the most posterior part. Okay. Then you have right ventricle is the most anterior part of the heart and the most commonly injured in trauma. So if someone gets punched in the chest, this is the one that gets damaged first because it's the closest one to the wall. Left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. Okay, so left ventricle is about 2/3 and right ventricle is about 1/3 of the inferior. Right, so on the bottom, so this is the bottom right here, and this is your diaphragm from here to here. Right, so that's your diaphragm. So the surface of the heart that's touching this diaphragm, and that's what it's talking about. So left ventricle touches about like 2/3 of it touches the diaphragm, and for right ventricle only 1/3 of it touches the diaphragm and the cardiac surface. Okay, we'll continue this. I believe we were here, pericardium. It consists of 3 layers from outer to inner. So it has fibrous pericardium on the outside, then the parietal pericardium, and then on the inside you have epicardium, visceral pericardium. Right. So that's the fibrous on the outside, the parietal and the pericardial over here, and then this is the epicardial or visceral pericardium. You have the coronary vessels on the inside, right between the myocardium and endocardium, and between the myocardium and the epicardium, right? So the pericardium has 2 layers basically, right? With the space, so it has fibrous and the parietal pericardium, right? These 2 layers. On this side, you call that pericardium as well, visceral though, or you can call it epicardium. So between the epicardium and myocardium, you have the coronary vessels, and all the way on the inside of the heart is endocardium. This is the one that would touch the chambers. Okay, so pericardial space lies between the parietal pericardium and epicardium, right? This and this. And pericardium innervated by phrenic nerve. This is important. Why? This is the reason why if you do have a heart attack or something, people feel pain in the arm, because phrenic nerve goes from the diaphragm to the shoulders, if you remember the dermatomes. Then you have pericarditis. It can cause referred pain to the neck, arm, and or one or both the shoulders. Often it's the left side. Okay. Coronary blood supply. So out of these, you need to know these 3 at least, and then all the other ones are just there. Okay, so coronary supply. Okay. Left anterior descending, so that would be this one right here. Okay, so when you think of this, think of it like on your own self looking down at the heart, and then it will be easier to think about it. So this would be on the anterior side, right? If you hold your arm out in an anatomical position for the heart, and then just follow it with the finger. So this is the anterior, left anterior descending artery. Okay, and then right. So LAD and its branches supply anterior 2/3 of the interventricular septum. This is important 2/3 on the top. Basically, on the inferior side, it's going to be this inferior or posterior side, right? So that's what that is. So anterior 2/3. So see, this is the septum. So it's going to be if this is the septum, it's going to be this area. So 2/3 of that area. So I guess that much is supplied by LED, right? Anterolateral papillary muscle is supplied by that too. Uh, those are the ones that support the valves, right? So it's the one that looks like this around the valves. So these are like your papillary muscles around the valves. Anterolateral papillary muscles and anterior surface of the left ventricle. So that's easy. Most commonly occluded, right? So when they have ischemia or something, it's going to be this artery. That's the most common artery that gets occluded. Then you have PDA, which is posterior descending posterior 1/3 of the interventricular septum. So if you're still in your anatomical position with your hand, you just pull it out a little forward and then you can see the back of the heart. So the back of the heart is going to look like this. Now your thumb's going to be on that side, and then you have your arm coming in with the pinky here and your middle finger here and like that, and like your thumbs like that. Okay, very demented hand. But yeah, so on the pinky side you have the PDA, posterior descending artery, right? So it supplies the posterior 1/3. So that's this 1/3. Okay, so now the interventricular septum is like this on this side, right? So now it's going to be the bottom part. It's going to be this bottom part right here. Sorry about that. Or that bottom part that's not covered. Okay, so it supplies the posterior 1/3 of the interventricular septum, posterior 2/3 of the 2/3 wall of ventricles, right? Okay, so the ventricle itself, its walls, it's going to supply, and posteromedial papillary muscle. So this one also supplies the valve muscles. Okay, the posterior medial ones. So this is the posterior medial, and this is the anterolateral. So it's important to know this difference because they might give you like I don't think they'll give you an ECG, but if you have to figure it out from an ECG or something, or they'll just tell you that there's an occlusion in the anterolateral part. So which artery is it and what other structures can get affected? Then you need to know that's like PDA, and the structures that get affected are the posterior medial papillary muscles, 1/3 of the interventricular septum, and the posterior walls of ventricle, around 2/3 of it. Yeah, right. So like that. Right coronary artery supplies the AV node and SA node. That's important. Okay. Infract may cause nodal dysfunction. So if there is a thrombus in there or an infarct or something around this area, that will cause decrease in supply to AV and SA node, and that will cause nodal dysfunction. So then if that happens, you get bradycardia or heart block, right? The right acute marginal artery supplies the right ventricle. Okay, that's this one, anterior marginal artery. Okay. Yeah, so that comes from the RCA, which is the right coronary artery. Okay, so don't confuse your cornea with carotids and cerebral arteries. Okay, so RCA is for right coronary artery in the heart. Okay, so EMA. Again, this is on the, if you still have your hand out as an anatomical position, put it like that, it's on the side of your thumb. So where your thumb is, that's where that would be. Okay. Because your thumb would be right here. So okay, bradycardia. That about covers that. Now, sometimes this artery right here, it can get supplied by this one instead of this one. Okay, so we'll read about that. So dominance, right dominant circulation, most common. So most people will have this kind of circulation. So PDA arises from RCA. Sorry, I meant this instead of this can get from that. Okay, so PDA. So that again, this is posterior descending artery. Okay, it's on the back side. This would be like right above your pinky here, so right there. Then you have, yeah, so this one is coming from orange, and the orange one's right here. So if you look at it that way, this orange will go keep on going, and then you turn it around. If you flip this, it's gonna be like this, and then the orange comes in with the PDA, right? And there's also left dominant circulation, right? So they might tell you that they checked the patency of RCA and it was clear, but then there is PDA that got occluded. So how is that possible? It's possible because the PDA here is getting supplied by the left dominant circulation or the left circumflex artery. So LCX is the circumflex artery, so that's this one right here. So LCX is this thing right here, the green, and that comes from, if you flip this over, it's right here. So LCX is coming from the left coronary artery, right? So the pink one. So the pink one is coming from here, from the, I guess, origin of the aorta to travels at the border of left atrium, and then it goes behind the left atrium, and then that's where the left circumflex artery can turn into posterior descending artery in some people. And then you have obtuse marginal artery, so that's this thing right here. That's just another name you have to remember, but they will ask you about that. What you have to remember is left circumflex artery. Okay, so if a thrombus was to come over here, how is it going to travel? It's going to travel from coronary sinus to or whatever supplies this, left carotid artery to left circumflex to posterior descending, or it can come from right coronary artery and go straight into PDA, posterior descending artery. Right? And then there's there's some people who have both of the circulations, so they have PDA arises from both left circumflex artery and the right coronary artery. Okay. Coronary blood flow. Okay, so if you weren't aware of what I meant by anatomical position. No one's holding it up. Yeah, that's the anatomical position of the heart right there, right? So that's how you would hold it. So just pretend like you're holding it like that, and then the thumb part would be the anterior and the pinky would be the posterior. Okay, then you have coronary blood supply from the left ventricle, so that's where it comes from. Left ventricle and interventricular septum peaks in early diastole. Okay, sorry, never mind. So coronary blood flow to left ventricle and interventricular septum peaks in early diastole, and coronary sinus runs in the left AV groove and drains into the right atrium. Okay, both of these things are important. So what it means is, let's see, when the say the heart starts pumping, right? So when it pumps, what happens is it's using up all its energy, and all the energy it uses up, the muscles are going to require what? It's going to require blood that's oxygenated, right? So all the blood gets, and there's increase in resistance because it's contracting as well, right? So that's why when it relaxes and or it's in diastole, in ventricles, that's when the resistance decreases and the blood flows to uh, through the coronary vessels, right? So coronary blood flow to left ventricle and interventricular septum peaks in early diastole. This is also the time when it's gonna be the most oxygenated you're gonna find in coronary blood flow, because when it goes into systole, all the blood becomes deoxygenated right away, and that's why coronary sinus contains most deoxygenated blood in the body. Okay, because it gets used up by the heart right away. So there is a question, and that's me telling you the answer for it. So they're gonna have, okay, so which part of the body contains the most deoxygenated blood during systole? During diastole or systole, one or the other, and then they're gonna give you option like the brain, the kidney, medulla, uh, splenic flexure, stuff like that, to make you think it's a watershed question, but it's not. It's a heart that uses the maximum amount of oxygenated blood. Okay, and then you have coronary sinus run in the left AV groove. You need to know this location because they will ask you this, and they'll be like, okay, so where does coronary sinus drain? Right, it drains into right atrium. Okay, so right there, it would drain. Okay, so let's get rid of all of this. Okay. So remember, right atrium has the right coronary artery, left atrium has the left coronary artery. Right atrium goes into the back and then turns into posterior, posterior descending artery. Left coronary artery goes around the left atrium as left circumflex artery, and then it could turn into the posterior descending artery. But RNR is the most common one. Sorry, PDA, RP. So RCA and PDA is the most common one. It could be that it's both of this, or it could be just the left. Uh, the bottom of, okay, so what it supplies is left anterior descending artery supplies the anterior 2/3 of the interventricular septum, the anterior side of the left ventricle, and the anterolateral part of the papillary muscle. Okay, the posterior descending artery does the posterior side of the interventricular septum, 1/3 of it, the posterior wall of the ventricles, 2/3 of it, and posterior medial papillary muscles, right? And then you have right coronary artery, the most important one, which supplies the AV and SA node. Infarct may cause nodal dysfunction, bradycardia, heart block, and then you have right acute marginal artery supplying the right ventricle. Okay. Now we're on to physiology. Cardiac output variables. Okay. Stroke volume. Stroke volume is affected by the contractility, afterload, and preload, right? So increase in stroke volume is caused by increase in contractility, for example, anxiety or exercise. Increase in preload is, for example, is in early pregnancy, right? Because remember, blood volume increases. And then decrease in afterload also causes increase in stroke volume. Okay, so this is basically how much is left over after systole, right? Or that. Then you have that's how you remember it. Stroke volume affected by contractility after load and preload. Okay. Failing heart has decreased stroke volume. So systolic and or diastolic dysfunction, right? Because a failing heart would have what? Decrease in contractility. So that would decrease in this. So if we were to put it into a formula, that would be SV equals contractility and preload over afterload, right? So, because I guess it would be times here. So, if contractility goes up, stroke volume goes up. If preload goes up, stroke volume goes up, because there's more to go give in cardiac output, right? Even contractility will help with the cardiac output. What won't help is like if this goes up, this goes down, right? So afterload goes up when there is oh, it's raining outside here. Cool. When there's leftover fluid after the systole, right? So if there's leftover fluid, that means that much fluid didn't add to the cardiac output, so stroke volume is lowered, right? So you can think of it that way. Okay. Contractility. So there are certain things that can increase and decrease it. So which ones increases it is contractility and stroke volume increases with catecholamine stimulation of beta 1 receptor. Remember, beta 1 is the heart one, and it increases heart rate, contractility, increases renin production as well, right? So activated protein kinase A. Okay. So phosphorylation, active calcium ATPase increases in calcium storage in sarcoplasmic reticulum. Remember that from biochem, I think. But similar concept here too. Yeah, I'm not gonna be able to find it right now, but I hope you remember that one. Okay. And then you have activated protein kinase A, which increases calcium. Remember the GS protein and all that? That's what I was talking about. That's what that is. Increase in calcium storage in the sarcoplasmic reticulum. So activated protein kinase A, calcium channel phosphorylation, increase in calcium entry, increase in calcium induced calcium release. Okay. Again, calcium is the most important ion for heart because this is the one that causes contractility, right? And heart has its own supply of calcium intracellularly, unlike the other ones where calcium needs to come from outside. But in heart, they have a vesicle that contains calcium and it has receptors on it. So those receptor gets depolarized by sodium. So to say increase the amount of calcium intracellularly, we give digoxin, right? So what does digoxin do? Digoxin blocks that channel, the sodium potassium pump. Potassium always goes out and sodium comes in, right? So when you block it, what happens? Sodium stays inside the cell. I hope you're following this. So see, this is the cell, and then you have one that contains calcium, right? So this contains calcium, right? And these vesicles have calcium receptors here, and then you have Na coming in through the sodium potassium channel, and sodium potassium. So potassium's gonna go out, and sodium's gonna and A just I'll just write Na comes in, okay, and then potassium goes out. So when you give digoxin, it blocks this pump, right? It blocks that pump. So what happens? The sodium you have inside is not going to be able to go out, okay? It blocks the active channels, so it can leave through like passive ones, but there's so much that's going to be negligible difference. So as long as there's sodium inside, it's going to keep attaching to this and keep the calcium coming out for longer times, and that causes increase in contractility. That's why we give digoxin. Okay, that's why calcium is really important for heart. Uh, and this vesicles that I said, it's sarcoplasmic reticulum. Okay, so that's what that is. So we give catecholamines to increase storage of this, so this becomes bigger, so you can fit more calcium in it. And I got a message. Oh, thanks. Yeah. Okay. So someone sent my own notes to me, and I appreciate that. Let me send it here. So this thing, the GS protein, GI protein, so this is where the sarcoplasmic reticulums are, right? So through the whole this thing, and the depolarization actually happens because of sodium. So you just end up with this. So with this thing, uh, calcium from the sarcoplasmic reticulum then gets activated. This is it activates protein kinase C, but here we're talking about protein kinase A. That's this one, right? So this is the one that's going to act on it. Again, they both do the same thing. Remember, this also activates calcium. Remember, from biochem, I think, or I don't know. I remember right now, but yeah. So this thing will go on to. This thing goes on to activate calcium release from intracellular sarcoplasmic reticulum as well. Okay, this one inhibits this. Okay, the GI one, but this one activates it. Okay, so activated protein kinase A, calcium channel phosphorylation happens, calcium enters, and you have increase in calcium induced calcium release. So you have intracellular calcium increase and decrease in extracellular sodium, right? That's this whole thing I just said. So when you have decreased extracellular sodium, that means there's more intracellular. So there's decrease in activity of sodium calcium exchanger as well. Okay. Digoxin. So it blocks the sodium potassium. Okay, they gave it here. Digoxin. It blocks the sodium potassium pump. So you have increased intracellular sodium. So decrease in sodium calcium exchanger activity, right? So okay, so when I said that, they also exchange for calcium. So calcium will come in through this, and sodium. Sorry. No, I said the opposite. So sodium comes in and calcium goes out. Okay. That also happens. So there's calcium coming from outside as well as inside, I guess. Okay, so oh no. Okay, I got it. It's not this, it's this one. It's talking about this one. So increase in intracellular sodium, so there's decrease in sodium calcium exchange activity. So okay, so when they block digoxin blocks this as well. It blocks this and it blocks this, I guess. No. Okay, forget everything I said after I made sense and I stopped making sense, so don't listen to me when I start making sense, okay? I'm confusing myself now. So increase in intracellular sodium will cause decrease in sodium calcium exchange activity, which increases this. This is the main thing you gotta remember. There's increase in intracellular calcium, and intracellular calcium causes contraction. We'll do that in musculo, but there's like myosin and all that stuff, right? Troponin C and all that stuff that does the contractile. It's similar to that. Okay. Then you have contractility and stroke volume decrease with. So these are the ones that decrease the stroke volume. Okay. So you have beta 1 blockade. So if beta 1 is responsible for increasing heart rate, increasing contractility, increase in renin, and there was a third thing I don't remember. Uh, but so if you block that, what's going to happen? Heart rate will go down, uh, contractility will go down. So if that goes down, stroke volume goes down. Heart failure with systolic dysfunction, acidosis, hypoxia, hypercapnia, a decrease in PO2, increase in PCO2. Okay, so hypoxia, hypercapnia. Then you have non-hydro pyridine calcium channel blockers. Okay, we'll learn about this in the pharmac section of CVS. Okay, so when you have decrease in oxygen, okay, this is an important concept too, because remember up here we just talked about coronary vessels. They require oxygen to function and to have left ventricle contract. So if you don't have oxygen, there won't be ATP. If there's no ATP, there won't be any contraction happening, because in that whole complex of troponin, myosin, and all that, you need ATP for contraction to happen, right? And you need oxygen for that as well, because oxygen goes into the uh, electron transport chain into the mitochondria, and mitochondria makes ATP. Okay. Uh, so when that's decreased, you won't have contraction, so that will decrease contractility, thus decreasing stroke volume. Okay. Acidosis, just remember that. They won't test you on CVS for acidosis, they'll test you on renal and respi, mostly for that. Okay, so heart failure with systolic dysfunction. Again, heart failure is what? It could be compensated or decompensated, right? If there's systolic dysfunction, that means it's decompensated, and that will cause decrease in contractility. In compensated, their contractility ejection fraction is preserved, and decompensated, it's, it can't compensate for the loss of that. Okay. Preload approximated by ventricular end diastolic volume. Depends on venous tone and circulating blood. Okay, so end of diastole, right? So what is diastole? Again, this is your left atrium, this is your left ventricle. Okay, so is the amount of blood when this relaxes, right? So when this relaxes, the aortic valve closes and the mitral valve right here will open, and when that opens, the blood from left atrium will go into left ventricle, and this process is known as the diastole. So the amount of blood that comes in here is known as preload. Okay, so everyone has preload and it's normal. The only time it's not normal is right here. So preload, approximately that. It depends on the venous tone. So if the venous tone is low or the circulating blood is low, right? So the blood that's coming in, the venous return is low, then this blood going in here will be lower. It could be that there's also in aging, I think. I'm not sure. We'll do the changes in age. I forgot. That will lower up the cavity as well. Hypertrophic cardiomyopathy might also lower it. We'll see. I'm not sure. Don't quote me on that just yet. But just understand what preload is, right? So it's the blood coming in. If the blood coming in is lowered, preload will be lower. If the blood coming in is higher, like in pregnancy, blood volume increases, so preload will be increased in that. Okay. So it depends on venous tone and circulating blood volume. Vasodilators, right? So vasodilators are going to do what? They're going to dilate the systemic vessels, right? So when that dilates, the blood starts pooling in at least the veins, right? Because they don't have the valves. So when they start pulling there, what's going to happen to the venous return into the inferior vena cava, right? Just imagine this already now. Right atrium, this whole thing. So this is going to decrease, right? Because now it's pooling in the veins. So if the blood coming in is decreased, it's gonna do what? Decrease your preload, right? So nitroglycerin, this is important. We give this in heart failure as well, because in compensated heart failure, you'll have basically hypertension or increase in blood volume. That and since your heart is already working overtime, you don't want to increase the workload. So for that, we decrease the workload by giving them nitroglycerin. Okay, heart load, afterload. Sorry. Uh, what is afterload? So afterload approximated by mean arterial pressure. So what happened? Let me start again. Okay, just ignore that part. Okay, so mean arterial pressure, just so you know the formula. I don't know, have they given it? I don't want to end up doing a formula and then they give it. Okay, so that's what it is right there. It's 2. Okay, I don't like how they wrote it, so I'll write it out. So, map, MAP equals systolic volume plus 2 was it 2? Yeah, 2 diastolic volume. Let me just confirm I'm not giving you the wrong one. Yeah, and it's all divided by 3. All divided by 3 because there are 3 values, right? So this is what they wrote. So they wrote 1 over 3 for systolic and 2 over 3 for diastolic, I think. 2 over 3 for diastolic plus 1 over 3 for systolic, right? So I write it like this because it's easier to comprehend for me. So systolic plus 2 diastolic divided by 3 gives you mean arterial pressure. Know this formula because it could come in handy if they're asking a question for this. So afterload, again, afterload approximated by MAP. Okay, so mean arterial pressure. Increase in wall tension per Laplace's law, increase in pressure, and increase in afterload. So LV compensates for increase in afterload by thickening hypertrophy in order to decrease wall stress. Okay. So left ventricle compensates for increase in afterload by thickening or hypertrophy in order to decrease wall stress. Okay. So when I say what's left over, that's not ideally what you should be thinking of. So what is wall stress? So say this is your left ventricle, okay? And it's like that, okay? And then when blood comes in and it's all end of diastolic, right? After end of diastolic, what happens? The coronary artery is going to supply the oxygen to the muscles of this left ventricle. It's going to use up, and then it's going to contract. So when the contraction happens, so think of it like a link, like this, like that, right, and then like that, similarly. So the muscle fibers will link up to each other, and when that contraction happens, all this will get pulled in together, right? So when that gets pulled in, this goes inwards, right? This goes inwards, so that all the blood can go through the aorta over here, and through the aorta, right? So that's contraction. So the amount of wall stress it takes in, or the muscle fibers they're in, the amount of work it can do is what the afterload is based on. So if it can't take in that much stress from the blood, basically, then the afterload will increase. If it's nothing for it, it's like, oh, dude, I can just do this in my sleep kind of thing and just push the blood out the aorta. That means there's not going to be any afterload. Okay. So is the increase in wall tension. So wall tension happens when the muscle fibers, something's wrong with those. Okay, so increase in wall tension, per Laplace law, increases pressure. Okay, and this increase in pressure will increase afterload. Okay, so what can happen to this? It can get fibrose due to ischemia or something like that. Like, MI. So LV compensates for increase in afterload by thickening or hypertrophy. Okay, so now that these muscles are not able to, uh, you know, pick up the pressure from the blood inside or pick up the load, what's it going to happen? These things are going to get trophied. And remember, trophy, you like them big, so hypertrophy means bigger cells. It doesn't mean cells get multiplied. That's hyperplasia. Don't confuse that. Okay, so see, this muscle fiber is now going to get hypertrophy like that and like that. Right, the muscle fibers are now from that to this. So and you can imagine you have like hundreds and thousands of these in your heart, and if they all get big like this, what's going to happen to this border? It's going to get bigger, right? Like that. So that's called hypertrophy. In hypertrophy, I guess the cavity stays the same, but it's going to be just this side. This side is going to stay smaller. It doesn't affect the interventricular septum because they don't push the blood. What pushes is these fibers right here, so these are the ones that are going to get big. Okay. This is a important distinction because this is how you're going to distinct it from a hereditary hypertrophic cardiomyopathy to hypertrophy of right and left ventricle. Okay, this is it. In the hereditary one, the interventricular septum and the left ventricle, they both get big. Okay. Hopefully that clears that up. Left ventricle compensates for increase in afterload by thickening or hypertrophy in order to decrease the wall stress, so it can handle this. Arterial vasodilators. Also, if there's increased systemic resistance, that's also gonna increase your afterload. I don't have to give that here because then this has to work harder, right, to get the blood flowing outside. So to do that, because the vessels are now a little smaller, because of the systemic vascular resistance increase, so that means the heart has to work harder. So that will also create increase of myocardial cells. Okay, so atrial vasodilators, for example, hydralazine, decreases afterload. So what do these do? This is a hypertensive drug, right? So it's gonna decrease the systemic vascular resistance. So if that is decreased, my bad. If that is decreased, what happens? Again, this one doesn't have to work as hard now, so it will decrease the afterload. ACE inhibitors and ARBs decrease both preload and afterload, right? Angiotensin converting enzyme inhibitors, because this also causes vasocontraction, right? Angiotensin receptor blockers. So if you don't have angiotensin 2, right? Angiotensin 2 is a vasoconstrictor, so you're going to block that. So that will also cause decrease in both preload, because there's going to be decrease in venous return, and afterload, because there's going to be decrease in systemic resistance. Chronic hypertension, increase in MAP, will cause LV hypertrophy. Again, this is MAP, systolic plus 2 diastolic divided by 3. So if or you can just think of it like, so in chronic hypertension, what happens? Again, this is a different concept than this, but similar. So in a vessel, right, say this is a vessel, and you constantly have blood flowing through it, right? And the blood is now getting increased. It's pushing harder and harder. And then the vessel now, remember, vessels also have muscles in them. They're called what? Intima, medial, and external, right? So it has three layers. Let me go into that. Okay, so it's called tunica intima, tunica media, and tunica externa. And just like any muscles exercising, uh, if there's a lot of pressure coming to it, it's gonna get hypertrophied, right? So that's what happens to vessels as well. So uh, when these get bigger, what's gonna happen to the vessel? The systemic resistance get bigger as well. At first, it's gonna take all the pressure because it doesn't have the muscles to fight it, but eventually it's gonna grow muscles, and then it's gonna increase the systemic resistance. So when this, no, we don't need that now. So when we have this, there is an increase in systemic resistance. Uh, what happens to the afterload? It increases. What happens after there's increase in afterload? Uh, there is increase in wall stress. So increase in wall stress will then the LV will compensate for it by making its cells bigger, so hypertrophy. So that's why you have left ventricular hypertrophy because of that. Okay. And I keep doing that. Make it smaller and black. Cardiac oxygen demand. Myocardial oxygen demand is increased by increase in contractility. That should make sense now. Increase in afterload proportional to the arterial pressure. That should make sense now. Increase in heart rate. Okay, we didn't do it, but we sort of did it. Right. Increase in diameter of the ventricle. So that will also increase wall tension, and this happens in during decompensated heart or dilated cardiomyopathy, right? So when you have dilated cardiomyopathy, that will increase wall's tension as well because now it's trying its best, but it can't, contract to the same diameter it used to. Okay, so all of this will increase oxygen demand. Coronary sinus contains most deoxygenated blood in body. Okay, there you go. So this, I guess I wrote it up there, but this is important here. Coronary sinus contains most oxygenated blood in body. There will be like a question on it, and now you know what the answer is. Wall tension follows Laplace law. So wall tension equals pressure times the radius. The bigger the radius, the bigger the wall tension. That's why increase in diameter of ventricle has increase in oxygen demand. Increase in pressure also increases wall tension. That's why we have increase in afterload causing hypertrophy as well, right? So wall stress is proportional to pressure times radius divided by 2 times the wall thickness. Okay. These formulas not really that important. Just know what the Laplace law is, or even if you don't know, just know the physics that I just taught you, and you'll be good. Cardiac output equations, equation and notes. Okay, so now we're doing stroke volume equations for all of these. So stroke volume is equal to end diastolic volume, that's the ventricle filled up to the brim, minus end systolic volume, that's the empty ventricles to the bottom, right? So how much is it filled minus how much is left over is what your stroke volume is. So yeah, so you can imagine if the leftover is more, then you have a decreased stroke volume, right? Because that's a bigger minus than a minus number or a number you're subtracting is bigger, right? If you have a higher end diastolic volume but a zero end systolic volume, then you can imagine stroke volume being increased because cardiac output is increased now, kind of like that. Okay, because remember, cardiac output is equal to stroke volume times heart rate. So if stroke volume is increased, cardiac output is increased. These two are attached to each other. Similarly, in 1 minute, say a person has a heart rate of 60 compared to a person who has a heart rate of 80. So the 81 has an increase in cardiac output than the one that has 60, right? So like that. So stroke volume equals EDV minus ESV, and systolic volume. Ejection fraction. Ejection fraction is systolic volume divided by end diastolic volume. Okay. Which is equal to end diastolic volume minus end systolic volume divided by, again, end diastolic volume. So ejection fraction is an index of ventricular contractility, decrease in systolic heart failure, usually normal in diastolic heart failure. Okay. So this is important because this is how you're going to differentiate between compensated and decompensated heart failure. Okay. That's the only time this is going to be important anyways. So ejection fraction normally is around like 55 to 65, I think. So anything lower than that would be like decompensated. Okay, so ejection fraction is an index of ventricular contractility. That's what it determines. Okay, so a decrease in systolic heart failure. So systolic heart failure, what is that? It's when left ventricle can't push, right? It can't push the blood out. That's the systolic heart failure. So if that can happen, then stroke volume is going to be lower, right? If a stroke volume is lower, then cardiac output is lower. Cardiac output is lower. That's a heart failure. Right? Why is it normal in diastolic heart failure? That's a filling problem, right? It's not a whatever is filled in. The left ventricle can still push it out. Whatever is filled in. So ejection fraction is preserved there. That's what it means when I say EF is preserved. I'll just say EF because for some reason I feel like this is a tongue twister for myself. So EF is preserved in diastolic because left ventricle is still functioning, right? To like, it can push out blood. It's just the diastolic heart failure. So the blood coming in is the problem. Maybe it's not enough blood coming in, or too much blood coming in, or something like that. Because diastolic is depend on two things, right? Where'd it go? Preload. So preload approximated by ventricular and diastolic volume depends on venous tone. Yeah, so venous tone and circulating blood volume. So venous tone is like the veins, right? If you have hypertension, then you're gonna have this problem right here. Okay, now you have cardiac output, which is stroke volume times heart rate. Okay, in early stages of exercise, cardiac output maintained by increasing heart rate and increase in stroke volume, and then in later stages, the cardiac output maintained by increase in heart rate only, because stroke volume has plateaued. Like once every single muscle fibril or cardiac muscle fibril is used up, is activated basically. You can't activate more because there are a limited number of cells. So then the stroke volume is going to plateau, right? But you can still increase heart rate. Okay, as they all sync up, there will be increase in heart rate. Okay, sync up. Why? Because of the AV node signals, electrical signals. Okay, so diastole is shortened with increase in heart rate. Okay, because if it's beating so fast, there's not enough time for it to fill up. So again, this is the ventricle, and then this is your atrium, like an ice cream cone. So if this keeps on beating really fast, like boom, 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 what's gonna happen to the feeling? It's gonna be, before it's even like filled up, touches the bottom, it's gonna get pushed out the aorta, right? Again, fill up, pushed out the aorta, fill up a little, push out the aorta. So the filling is decreased now compared to when it was normal. it would fill up for like a whole half a second or whatever, and then get pushed out, right? But at this point, it's beating so fast that it's really low and then gets pushed out. Okay, so diastole is shortened because of that when there's increase in heart rate. For example, ventricular tachycardia. So there will be decrease in diastolic filling time, which decreases stroke volume, right? It affects stroke volume because cardiac output is lowered too now. There's less blood going out. Pulse pressure. Pulse pressure is systolic blood pressure minus diastolic blood pressure, right? So it's basically, say you have 135 systolic and you have like 89 or just 90 diastolic. And then you take the systolic, subtract the diastolic from it, so that would be, say this is the baseline, this is diastolic, this is systolic number. So you, at this point I'm just teaching you math for some reason. Yeah, so when you take that out, this part is what's left over, and that's called the pulse pressure. Why is this important? Because pulse pressure, they'll probably tell you. Pulse pressure is directly proportional to stroke volume and inversely proportional to the arterial compliance. Okay. So what that means is, what's better, if pulse pressure is higher or lower? Higher is bad, lower is bad as well. They both are bad. It should stay normal, within the normal range, which is what? So 120 minus 80, that's the normal. So increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, increase in sympathetic tone, anemia, exercise transient, that's just transient. So pulse pressure decreases between these two, right? Because increases between the two, because diastolic is going to be decreased, preload will decrease, but heart rate and contractility increases. So systolic blood pressure will be much higher than diastolic, so this will be much lower and this will be much higher. So this thing. This will be much higher, right? Okay. Increase in pulse pressure. Okay. How much time do we have? 3 minutes. Okay, let's just take a break here. And we'll come back. Okay, let me finish this pulse pressure actually. Okay, so increase in pulse pressure in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, increase in sympathetic tone, anemia, and exercise transient. The decrease in pulse pressure happens in aortic stenosis, right? Cardiogenic shock and cardiac tamponade, and advanced heart failure. So aortic stenosis is when LV can't put out the blood into aorta fast enough because the aortic valve is stenosed, so it's blocking it, it's obstructing it, so it has to increase the pressure to push it out, kind of thing. The systolic blood pressure will be decreased in aortic stenosis, so it's going to be closer to the diastolic blood pressure. Sorry. Cardiogenic shock, that's just your heart muscles not functioning properly. Cardiac tamponade, that's the pericardial space has fluid, so it's pushing in pressure into the epicardium and then myocardium and into the myocardium, right? So that's what that is. It increases the diastolic volume, I guess. Okay, and lowers the systolic volume, blood pressure. Sorry, not volume. And then you have advanced heart failure. We already discussed that. So that takes care of the pulse pressure. Okay, we'll come back after the break. So they will give you a question with by telling you that the venous return oxygen content is like, say, 5%, and then arterial oxygen content is like 98% or something, right? So then you have to figure out what this number is, and they'll give you the rate of oxygen consumption, right? They'll give you all these three things, and then they'll ask you what is the cardiac output or something like that. So you have to remember that we have a formula for that. So the formula for that is rate of consumption goes up, and then you figure out how much oxygen is, used up basically from the time it left ventricle and by the time it returned to the right atrium. Okay, and so that number will go down here, and then you can figure out cardiac output with that. Another way is stroke volume and heart rate. Q is the flow, I think. But okay, so Starling curves. Here we have stroke volume. Here we have ventricular end diastolic volume on the x-axis, so that's going this way. So the higher number will be here. So this is the normal preload, and here it's decreased, and here it's increased, right? And then this is the normal stroke volume. The stroke volume here is increased. Here it's decreased, but it's higher than here. That's also decreased, right? So Starling curve. So force of contraction is proportional to the end diastolic length of cardiac muscle fiber, right? So say you have a balloon, right? So you have a balloon and you fill it up. So a balloon that was this small, and then you fill up fluid inside, and then it's gonna grow into this thing, right? It's gonna grow into this. So now you have blood all over in here. Okay, so this thing is gonna push onto this layer, or fluid that's gonna push onto the layer of the balloon. Okay, and now the recoil. Heart has the recoil muscles or the contractile muscles, right? So the more you push outwards, the more it's gonna push inwards, right? The more you push outwards, the more it's gonna push inwards. So that's what they're talking about. The force of contraction is proportional to the end diastolic length of cardiac muscle fibers. So those muscle fibers, if this increases, they will stretch more. So when they do go into contraction, that's how much work is increased, and they'll contract more, right? So more fluid, more contraction. So it's proportional to the preload and the thing. Okay. Increase in contractility with catecholamines, positive ionotropes, that's dobutamine, milrinone, digoxin. Okay. Some way or another, they'll increase calcium. Okay. In the intracellular. Decrease in contractility with loss of functional myocardium, for example, MI, beta blockers acutely, non-dihydropyridine, calcium channel blockers, and heart failure. So again, this thing we know is heart rate, contractility, and renin. Remember, renin's not appropriate here, but it's just so you don't forget that it has action on that as well. So beta blocker will decrease the contractility, we know that. With loss of functional myocardium, right? So, for example, MI, right? If these are fibros, this fiber right here, that's not going to function, so you're going to have decrease in contractility. Non-dihydropyridine calcium channel blockers, these are the ones that act on the heart, and they stop the calcium receptors. I forgot where it was. These things right here. So calcium don't come out. Okay, so I think that's what it is, but we'll check it out in farm after. Okay, resistance, pressure, and flow. Now volumetric flow rate, Q. So that's cardiac output is equal to this. Okay. So Q equals to flow velocity times cross-sectional area. Okay, so what that actually means is just, how much, if the cross-sectional area is increased, or like a big one like that, you're gonna have a bigger flow rate. If the cross-sectional is decreased, like this one is gonna have lower flow rate than a vessel that's this big, right?